treatment. We pay free HPV vaccination at Avenue. For the early detection, we conduct pre-screenings at Avenue every year. This is for the members that have purchased APF Femina Plus. And in the unfortunate case that you get diagnosed of either breast, cervical, or ovarian cancer, we pay a predetermined lump sum on diagnosis of either of the three. The eligibility is 18 to 60 years. 18 to 60 years, meaning any member who is between 18 to 60 years can join. But if you're below 18 years, you can't join because basically you're not yet at the entry age. Any member who has joined before 60 years is free to stay on the policy for life for as long as they are renewing their policy and paying their annual premiums. Apart from that benefit, the solution also comes with an Ask Nivi chatbot. This chatbot rides on WhatsApp. So what it does is for that particular member that has purchased this solution, they'll be able to get information relating to female health. Female health could be cancer specific or any other information that is specific to women. And it will be sending it weekly, and it will also nudge the member to go for the HPV vaccination, which will assist in the prevention, and also the screening at Avenue, which is done annually. Now, this nudging is there because there's a study that has been done, and it's been proven that early detection actually assists in reducing the mortality rate of some specific cancers. In terms of the options that are there, we have silver, gold, and platinums. The difference between the three is the premium payable. For example, for silver, it's 6,067 per annum. For gold, it's 12,094 per annum, and platinums is 15,108 per annum. The benefit payable, if you have come as a member, for example, myself as Deborah, I purchased gold of 12,094. If I get diagnosed of breast, cervical, or ovarian cancer for stage 1, I'll get 450,000 in cash. Remember, this is not a medical policy. We pay you cash for you can use this cash for medical expenses, for financial obligations that arise as a result of being diagnosed of the three types of cancer. When I progress to stage 2, I'll get 1.5 million. When I progress to stage 3, I'll get 1,875,000. When I progress to stage 4, I'll get 900,000. Now, you might ask yourself why the benefit under stage 4 is lower than the others. The reason for this is because at that point, there's no major treatment, but rather it's just the palliative care that is being done. So the average cost of treatment is usually lower for stage 4 compared to the previous stage where the major surgeries happen. In terms of the exclusions, we do not pay any claims relating to pre-existing cancer, meaning if I already have breast cancer, I cannot benefit from this policy. The reason is that this policy has been tailored to be a protection policy for future cases, not cases that I already have. The other exclusion is that any claims that will occur within the first 6 months of the policy is not payable. In insurance, we call it a waiting period. A waiting period is the period within which the insurance company will not pay any claims relating to a particular benefit until a member has served this period. But for APF Femina Plus, during these 6 months, you are allowed to go for screening and you are allowed to get the HPV vaccination. What you won't get in the first 6 months, it's just the lump sum. Then the other point that we need to take note here is if you purchase gold or platinums, you must go for those pre-screening within the first 6 months of the policy, as opposed to silver. The other exclusion, that's the third one, is that we do not pay claims where death has occurred within 30 days of diagnosis. And the reason for this is that there could be an element of misstatement of material information or misinformation, or you do not conceal some facts at inception because medically it's not possible for you to be diagnosed at this point, and within 30 days, these death claims, which brings us to now the fourth point, and that is misstatement of material information. And the reason for this is that for insurance, we are bound by the insurer, the principle of utmost good faith, whereby you need to declare, disclose, and do not misrepresent any information on your application form. In case that is flagged at claim stage, we will not be able to pay. So feel free to share this information with your members within your chamas, women group, your spouses, because this solution will be able to step in for you should you require medical, maybe a medical buffer, because I do understand some of you might be having medical insurance, but this will come in form of cash, which can help you pay school fees for your children, start up a business if, for example, you're not able to work, or any other expenses that will arise as a result of you being diagnosed. So as I end, I'll play a short video, then I'll hand over back to Justice. Thank you for listening to me. My name was Deborah Njoroge, and I'll be sharing our email address on the chat should you require further information or have questions regarding this particular solution. I'll hand over back to Justice.
Thank you very much, Deborah, for that informative session. And this goes to our clients. The purpose, or rather the importance of this product is just to ensure that we support you when in the event you have any of the diagnoses Deborah has pointed out. At this point, we'll go to the presentation. Daktari, welcome. I've seen you. We'll be able to have a Zainab who will introduce Daktari in the next 2 minutes.
Hello, Daktari, confirm you can hear me?
Yes, I can. Thank you very much.
I can see you talk, but I can't hear you.
Can you hear now? Hello, can you hear now? Because I'm unmuted.
I can't hear you still, eh?
Okay, I can see someone saying they can hear me.
Now I can hear you. Thank you so
right.
much. Karibu
Thank
sana,
you.
Daktari. I'm sure you must have missed on that part, but
Yes,
it's
I did.
okay.
Apologies
Otherwise, we
for
are humbled to
the
have you
delay.
this morning. To our viewers, karibuni sana. We are humbled this morning that you can take an opportunity to join us once more. Karibuni sana to APA Insurance, the home of happiness. And on behalf of the management of APA Insurance, we want to welcome you aboard to our today's discussion. And with me, I have Dr. Kristina Sule. Kristina Sule is an ops gynecologist. She's also the CEO of Alora Medical Center, based at 40 Suits, 7th floor. The reason why we brought her in today, I'm sure you must have been waiting for her to hear a cancer specialist. She has a great passion in the health of women. Despite her being a gynecologist, she also has a specialist in cosmetic gynecologist. So all this together gives her a passion, and she would love to see women live healthy and happy. And when we talk about women health, we incorporate everything that affects the women. That is why she was the best choice this morning, so that she can take us through. Otherwise, karibu sana, Dr. Christine. The floor is yours.
Thank you very much. Thank you so much, APA team. I really appreciate. Thank you for your consideration for me to present this topic. Yes, as been said, I am an obstetrician gynecologist. I'm a specialist cosmetic gynecologist in particular at Alora Medical Practice. It's 6th floor in 40 Suits in Upper Hill. The reason why it was important for us to discuss breast cancer today is because when we discuss breast cancer, there is always an importance for a value add for the patient when they listen to such a talk. And the actually very interesting thing is that studies have shown that when a woman senses that she has a problem with her breast, one of the first people that she is going to visit is actually her gynecologist. And then from there, her gynecologist will make a referral to different relevant doctors, because management of breast cancer involves a multidisciplinary team. So there will be a medical oncologist involved, there will be a breast surgeon involved, there will be a plastic surgeon, and there'll probably be a gynecologist. So I'll get into that later, but it's a multidisciplinary thing. And the first point of contact is usually a woman's gynecologist. So if we can just get into the presentation, Justus, please move to the first slide. Now there you have a picture of what the breast actually looks like. And why that's important to know is because many times when a patient comes to see a doctor, they're not quite aware of exactly what is happening with the breast. And these are the different parts of the breast. Sorry, please go back to the breast. Yeah, these are the different parts of the breast. We have the fatty tissue, we have the lobes, and then we actually have the glands. And the glands are the ones that produce milk. And the glands are connected to the nipple by a small duct. As you can see there, there's a place that says duct. And this particular unit that you're seeing on the right of the screen replicates itself several times in the breast. And when milk is produced, it is channeled outside to the nipple. And breast cancer can occur in any part of what is being shown. It can be in the lobe, it can be in the duct, it can be in the areola, it can be in the nipple, it can actually be anywhere. And there are very many different types of breast cancer histologically that can happen. And the reason why it's important for us to know that is because some are more aggressive than others. And where it occurs in the breast will affect how the disease presents itself and the kind of symptoms that the woman is going to experience. Next slide, please. So it's important for us to understand what exactly would cause a woman to have breast cancer. There are very many reasons why one would have breast cancer, as you can see, but there are some that hold more weight than others. If a woman is of advanced age, that is a risk factor for breast cancer. And it's also a risk factor for any cancer. With age, our risk for cancer really does increase. Now, exposure to estrogen is also a risk factor. For example, for women who have spent their life taking estrogen, either in the form of a pill or an injection, for whatever reason. Sometimes it's even something that's prescribed by a gynecologist. Sometimes it's the estrogen that you choose to have in terms of your contraception, but exposure to estrogen is a risk for breast cancer. And that risk is there not only early in life, but also even in menopause. For women who take up hormonal replacement therapy in menopause, that is a risk for breast cancer and even non-cancerous breast lumps as well. So estrogen is not great for the breast. Sometimes we have to take it because we have no choice. But yes, it does increase our risk for breast cancer. I'd like to mention also that for women who require hormonal replacement therapy, other forms of estrogen, such as vaginal estrogen, for those who have vaginal symptoms of menopause, are probably safer. And I'd also like to mention that estrogen taken as hormonal replacement therapy in menopause is also a cancer risk for endometrial cancer, which is cancer of the uterus. So it's very important that whenever you are placed on any hormonal therapy, whether it's for contraception, whether it's for management of menopause symptoms or for whatever it's the need be, it is important for a person to discuss their cancer risks with their gynecologist or any other doctor that prescribes hormonal therapy. Now, early menarche is also a risk factor, and this means women who start their periods earlier than others are at a higher risk of breast cancer. And the reason is because they will have a longer exposure to estrogen than a woman who starts her period later. And for those in the group who are mothers, you'll know that nowadays our girls start their periods quite early. Previously, women would start their periods at 13, 14, 15, sometimes even 18. But nowadays we have children starting their periods as early as 8 because of environmental factors and genetics. And this will increase their exposure to breast cancer because they will be exposed to estrogen for a longer time than a woman who has started her period later. Women who go into menopause late are also at a risk of breast cancer, once again for the same reason. because they will be exposed to estrogen for a longer time. And worse off, a combination of women who are starting their periods very early and going into menopause very late, they will be exposed to estrogen for a very long time, and their risk for breast cancer increases. The next risk factor is combination estrogen progesterone hormones, which is basically what I talked about, and that's the oral contraceptive pill. The risk is not massive, but the risk is there, and it's something that women need to be aware of even as they embark into hormonal contraception. Combined oral contraception is contraception that has both estrogen and progesterone. I'm sure many of you know it as the family planning pill, right? That does pose a risk. It's not massive, but it is a risk, and it's something somebody needs to be aware about. Nulliparity is basically women who do not have any children. They are at a higher risk of breast cancer. Ideally, it's not so much the fact that you don't have a child, but it's the fact that you have not breastfed, because breastfeeding protects us against breast cancer. So women who've breastfed many children are less likely to get breast cancer than those ones who have not. Doesn't mean that if you had many children and breastfed many children that you cannot get breast cancer. You still can, but the risk is significantly reduced. Alcohol consumption, of course, increases the risk. Alcohol consumption increases the risk for all cancers, not just breast cancer. And so, yes, alcohol consumption, of course, is never a good thing. You'll never go to a doctor who will, advise alcohol consumption, but it does pose a great risk for breast cancer as well. Genetics, this is actually a huge breast cancer risk. It probably even should have been first on the list. For anybody who has had a maternal relative or their mother who has had breast cancer, you are at risk of breast cancer as well. I'm sure most of you have heard of Angelina Jolie and how she had to have a double mastectomy. She removed both her breasts and both her ovaries because her mother and her maternal relatives had breast cancer, which put her at risk. She actually did not have cancer, but she did not want to endure that lifelong risk. That's actually how serious the risk genetically is. The reason for the ovaries is because ovaries are the ones that produce estrogen and progesterone. And as we've already mentioned, the ovaries are the ones that, once they produce those hormones, the estrogen and progesterone are the ones that provide the cancer risk. All right, specifically estrogen, actually, not progesterone, but specifically estrogen being worse than progesterone. And we'll get into that a little bit later in terms of the screening. Now, if you've had, if one of your relatives has had invasive breast cancer, or even just, an early detection, then of course you're at risk. Now, there's also women who have increased breast density. Sometimes when a woman does a breast ultrasound, it will be reported that the density of her breast is increased. Some women have normal density breasts and others have increased density breasts. So if you ever get an ultrasound where there is increased density of the breast, then that is a risk factor for breast cancer. And that generally happens after the age of 40, but for some women that happens even much, much earlier. So it doesn't mean that you have breast cancer, but it probably means that you have to keep a close eye on your ultrasounds or your mammograms. Now, exposure to ionizing radiation, this is basically the rays that are known to cause cancer. For example, X-rays, they do have ionizing radiation, so we should really limit that. And this is specifically for women who are involved in fields where they come into close contact with ionizing radiation on a daily basis or on a regular basis. For example, radiographers, radiologists, or women who live in towns where there are massive industries and factories that are producing ionizing radiation. And so it's important for them to quickly and constantly screen themselves, because ionizing radiation is a risk for breast cancer. So if you and you will be told by your doctor, for example, for women who have bone issues and they have to undergo X-rays very frequently, that is a very high exposure for ionizing radiation, especially if you are having X-rays of large bones like the femur, the hip. Those ones take up a lot of ionizing radiation and it becomes a risk. So it's something that you need to be aware of. Obesity is also a risk factor for breast cancer. Obesity is a risk factor for very many cancers, actually. However, with breast cancer, the reason why it's a risk factor is because we have certain hormones that are converted from one to another in fat tissue. So the more fat tissue a person has, especially a woman, the more conversion will happen from one hormone to another. Specifically, women who are obese and they are going into menopause late, there is conversion of other hormones into estrogen and testosterone and vice versa. So if you have hormones being converted in fat tissue into estrogen, that means that your estrogen content will be more than for other women. And the more estrogen that you have, the more your risk for breast cancer, all right? So women who are lean, their risk for breast cancer is usually much decreased as opposed to women who are obese. Now, it doesn't mean that women who are lean cannot get breast cancer. They can, especially if they have any of the other risk factors like not breastfeeding, alcohol consumption, genetics, and the rest. But basically, women who are obese will tend to have a higher risk because they are converting other hormones into estrogen in their fat, and they have a lot of fat, meaning they will have a lot of estrogen. All right. Next slide, please. So how do we then decrease our breast cancer risk? Of course, we decrease it, first of all, by decreasing the risk factors. One of the risk factors that was not mentioned in the previous slide is smoking. Smoking is a huge risk for breast cancer. So stopping smoking or decreasing of smoking and alcohol consumption can really decrease the breast cancer risk. And those are things that we can actually manage. You know, those are not things that we have to live with. You can actually stop smoking. You can actually stop consuming alcohol. Those are things that we can actually control to be able to decrease our breast cancer risk, and even just to be able to increase our health in general. This is not necessarily all about breast cancer. Things like obesity can also be controlled. There are studies that have been done for women who have decreased their amount of smoking, decreased their alcohol, or lost weight, and significantly improved their risk for breast cancer. And these are quantifiable numbers. So it's really important that we are able to control the things that can actually be controlled. If you're obese and you probably have one additional risk, like a maternal relative who had breast cancer, it would be wise to lose weight for your general health, but also to decrease your breast cancer risk. Now, early pregnancy is seen as a way of decreasing breast cancer risk. Easier said than done, especially in our current population and our current financial situation. Sorry, please go to the previous slide. In our current financial situation, people are probably not wanting to get pregnant early. And also, you know, women have now careers that they want to attend to, so they're not likely to get pregnant early. In fact, they're probably very likely to get pregnant later. But yes, early pregnancy is a decreased risk for cancer. Breastfeeding, of course, is a decrease of the risk. Also very important because nowadays hospitals, as much as they're trying to be baby friendly and encourage mothers to breastfeed, because breast milk is safe, it's it's affordable or free, it's sustainable, it's something that can be done for a very long period of time. However, some mothers do elect to give formula for personal reasons or for health reasons. But women who give birth and yet do not breastfeed will have an increased risk of breast cancer. So breastfeeding is not only good for you and the health of your baby, because you are passing immune protection substances to your baby through the breast milk, but you're also protecting yourself against breast cancer. So the baby receives immunity, which cannot be received in formula or any other form of feeding, but at the same time, you are decreasing your breast cancer risk. Exercise also increases the risk of decreases the risk of breast cancer. And the reason why it does that is because it keeps us lean. It helps us it protects us from being obese. And remember what we spoke about obesity and breast cancer, but just generally increased Cardiovascular health, which is what exercise generally brings, also decreases the risk of breast cancer. Here we are specifically looking at exercise being related to obesity. People who exercise regularly are less likely to be obese, and they're less likely to produce high amounts of estrogen, and they're less likely to get breast cancer. We have selective estrogen receptor modulators. These are drugs basically that are given to some women when they are noted to have, high levels of estrogen, or they've been diagnosed with a particular form of breast cancer, and they specifically target estrogen receptors and they decrease the amount of estrogen. We have other drugs called aromatase inhibitors. These are drugs that women just take from time to time, sometimes for fertility or other things. It's not a drug that you will take just to decrease breast cancer. It's a drug that you'll be taking for a different condition, but it's also known to decrease the breast cancer risk. There's also prophylactic mastectomy, which is what we spoke about with Angelina Jolie. It is women who have a very, very high family cancer risk who choose to remove their breast even before they develop breast cancer, because they do not want to be able to be exposed to that risk. Some women do, if you're doing it prophylactically, meaning prophylaxis means prevention. If you're doing a mastectomy to prevent breast cancer, you have to remove both breasts. It would not make sense to remove one breast. All right. So it would make sense to remove both. And some women choose to go that path, especially maybe if a mother, a cousin, a sister all have breast cancer, they choose to just be ahead of it. And this will involve also removal of the ovaries, as I mentioned, because the ovaries are the ones producing the hormone that is triggering the breast cancer, which is either estrogen or progesterone, specifically estrogen. There are some women who go for ovarian ablation. Ovarian ablation basically means kind of burning the ovaries surgically through either laser or MRI and MRI energy. And the reason why they would do that is because they don't want to have a surgery to remove their ovaries, but they do know that they are at a high cancer risk. And women who have ovarian cancer or have a family history of ovarian cancer also tend to do this. So ovarian and breast cancer are related because of the kind of hormones that are produced. All right, so we can go to the next slide. Right, so how do we screen for breast cancer? First of all, I'd like to mention that early screening really saves lives, because early screening can lead to detection of a lump, detection of breast cancer, and you can end up, getting away with a surgery that removes the lump without having much to do afterwards, or maybe minimal radiotherapy or minimal chemotherapy, as opposed to advanced cancer. Now, people usually tend to say that we have more breast cancer around right now. Yes, that is true. We do have more breast cancer as time goes by compared to previously, because we are more obese. We are being exposed to ionizing radiation in our environment. We are now having relatives who passed away from breast cancer. However, we are also detecting much more. So it may look like there's more breast cancer in the environment, but remember, previously, women were not able to detect it because our ultrasound machines were not, comprehensive enough. Our mammogram services were not comprehensive enough. Also, the knowledge was not out there. Women were not, having talks like this to be able to say, okay, how do we deal with this? How do we look for it? What are the risk factors? So as much as it seems that there's more breast cancer, but I can confidently say the detection is also much, much, much higher nowadays. Now, basically, the basics of screening, which we will get into just now, is a self-exam, all right? A self-exam is one of the basic ways. And the reason why we request women to do a breast exam, women and men, by the way, I should mention, because men can also get breast cancer. The reason why we make women and men do a breast exam is not because, as a doctor, I'm not trying to make a client diagnose themselves with breast cancer. I am trying to make them aware of the texture of the breast, so that in case they ever get a lump, they will be able to know what is normal and what is not normal. right? So when you know what is not normal, you'll be able to say, the surface of my breast has not previously felt like this. Now it feels different. I must go see a doctor. Or you'll say, I can feel a lump, yet, if you're lucky. And the reason why the self-exam is a bit limiting is because if you get a lump that is either too small or too deep for you to feel with your fingers, you can miss it. I have also missed breast lumps in certain patients, and that's the reason why it is just the basic of screening. We need to go to other modalities such as ultrasound and mammogram. So an ultrasound is able to detect breast cancer. And remember, when we talk about screening, we're talking about a person who has no problem at all, and they're going for a regular checkup for their breasts. All right. If you have detected a lump, that is no longer screening. Screening is when we are healthy and we are fine and we're just going for a checkup. So breast ultrasounds are very important. I usually encourage my clients to do them above the age of 25 annually. All right. To be able to detect things that you may have missed during the self-breast exam. It is also important to do mammography. Mammography or a mammogram is reserved for women who are over 40 because it does have ionizing radiation. And remember, we talked about ionizing radiation as a risk for cancer, and not just breast cancer, but even other cancers. Now, when a woman is above 40, as I had mentioned, the density of her breast changes. And now, an ultrasound alone is not sufficient to detect breast cancer. We need to add a mammogram. So ideally, you need to have a breast ultrasound and a mammogram annually after 40. It helps us to be able to see. An ultrasound will see the things that the mammogram has not been able to see, and the mammogram will see the things that the ultrasound will not be able to see. And so the two are seen side by side, all right? Now, of course, a clinical exam is important. That is an exam by a doctor. A doctor is more likely to detect a lump than you self-examining yourself. However, even a doctor can miss, and that is the reason why we add ultrasounds and mammograms. In certain cases, we're also forced to do magnetic resonance imaging, or sometimes we're forced to do molecular breast imaging in certain patients. All right, next slide, please. Now, if you get nothing out of this presentation, I would like you to at least get this, how we do a self-breast exam. We have 3 ways of doing it. The first way is in the shower, the second is in front of a mirror, and the third is lying down. And preferably, all 3 need to be done. And this is something that women need to do once every month. And it's easy to do. And once women familiarize themselves with the texture of their breast, this becomes easier and easier, and they're more attuned to be able to notice when there's a difference. So basically, in the shower, women are encouraged to pass their fingers over the breast in a circular motion, starting from one quadrant, going towards the center. And remember, something that I'd like to mention is that our breast tissue extends into our armpits, for those who didn't know. So the breast, as you noticed in the first picture, is round, and then it has something we call a tail. And that tail is a piece of breast tissue that extends into our armpit. So it's very important to be able to touch the armpit area and feel it with our fingers to be able to know whether the armpit is also having a breast lump. All right. And women are encouraged, even those women who do not undergo self-breast examination, if they ever get any armpit thing that they're unsure about, to see their doctor, because for some women, that is how their breast cancer is discovered, when they get a pimple or a lump in their armpit. So it's a circular motion. In the shower is a little bit easier because usually hot water makes the breast tissue soft and it makes it less uncomfortable to examine. And if there are any changes, the woman is encouraged to note these changes. Another way is in front of a mirror, because remember, in the shower, you cannot see your breast. You can feel it, yes, but you cannot see it. In front of a mirror, you'll be able to notice skin changes, which can be a part of the symptoms of breast cancer, which we're going to go into just now. But in front of a mirror, you can not only feel, but you can also see the changes. And once again, you have to stand in front of the mirror, place your arm over your head, and start in a circular manner, going over the breast, see how they feel, but at the same time, look and see if there are any visual changes, anything on the surface that you're able to notice, or even deep down inside. And then the other way is lying down. Lying down allows the breast tissue to be spread out perfectly, and it also gives the client a sense of level of comfort. Usually you're supposed to put a pillow under your right shoulder, and once again, raise your arm above your head, and then go again in a circular manner. And remember at all times to change the pressure of the examination. You can go from light to medium and then to firm. Don't bruise yourself. Don't harm yourself, but just be able to press and feel out each area. And if this is something that you do every month on both breasts, you will be able to become familiar with the texture of the breast, such that if anything goes off, you will definitely know. Next slide, please. So what are some of the symptoms of breast cancer? It's important for us to talk about the symptoms because many times patients are the ones who bring it to the attention of the doctor that something is off, right? Yes, a doctor is capable of diagnosing, but actually the patient plays a big part. They come and say something is off, and that's the time now when we start examining. So if the client themselves do not know what is wrong, then it's very difficult for the doctor to start investigating unless they were to come for their annual check. And this is why it's so important that we play a role together. The patient knows what is off, and also now the doctor can give further advice. So any swelling that is felt on any part of the breast or the entire breast, even if it's not a lump, and even if a lump cannot be felt, is a cause for concern. That is something that you need to bring to the attention of your doctor. Now, swelling is never a good thing, regardless of any part of your body, but it's important, whether it's a small part or a big part of the breast, you can just tell the doctor that this breast of mine actually looks or feels bigger than the other breast, and that was not previously there. And then now we start our investigation. So swelling, even if you cannot feel a lump, remember we mentioned that lumps can be missed both by yourself and by the doctor. But if you yourself feel that there's swelling of the breast, you need to bring it to the attention of the doctor. Then also dimpling. Have you ever seen the surface of an orange? The way it has tiny little depressions, tiny little depressions. Sometimes we call it orange skin peel for the doctors who examine it, and it's even described in textbooks and literature. It's actually a French kind of description. It's called peau d'orange. And any woman who gets dimpling on the skin of her breast, basically needs to be able to bring this to the attention of the doctor. But the reason why we educate you so that you can even know what that looks like. So if you've ever had a look at the skin of an orange or the peel of an orange with the tiny little dots and depressions, in cancer, in breast cancer, the breast starts to look exactly like that. All right. And so that's a huge red flag and something that you need to bring to the attention of the doctor. Pain, whether it's nipple pain or full breast pain or the pain of a section of the breast, that is definitely something to bring to the attention of the doctor. Any pain is not good, regardless of where it is in your body, but breast pain is a red flag. It is better to see the doctor and be reassured that it's actually nothing to worry about, as opposed to live through the pain or persevere and then later on find out that it was something serious such as breast cancer. So any woman who experienced breast pain, and remember, some women experience breast pain even when they're breastfeeding, all right? But if it's persistent and it's long-standing, that needs to be brought to the attention because breast cancer can be detected even in pregnancy or in lactation. So it's important whenever there's pain to be able to go and see a doctor. You'd rather be told that there's, a blockage of a duct or breastfeeding is having a challenge, but not breast cancer, all right? Nipple retraction, meaning the nipple is supposed to project outwards. When the nipple starts to project inwards, then that is a cause for concern. It means that there's something pulling it from the inside, and it's important for us to review that because all of these are actually symptoms of breast cancer. It is better to be told that your nipple retraction is genetic as opposed to you have an inward facing nipple that used to face normally and be protruded, and now all of a sudden something has changed and you ignore it. The other is redness or flaking or thickening of the skin. Now, you see, it would be very difficult to know exactly what this is if you do not know what the normal breast skin looks like for you, right? So once you know what normal looks like, then you will know when the flaking on the skin has occurred, or the skin in a particular area is feeling more thick than in the other areas, or if there's redness in a particular area. So any of these are actually red flags. If there is nipple discharge other than breast milk, meaning you're not breastfeeding, and all of a sudden your breast is discharging either milk or any other discharge, meaning you're not in a breastfeeding period, yeah? But all of a sudden your breast is releasing some discharge from the nipple, especially if that discharge has or is looking like it has pus or it has some form of redness, meaning it has blood spots, or it has any other strange color. Anything other than pure breast milk during the time of breastfeeding is actually a concern. Even if you're having breast milk at a time when you're not breastfeeding, maybe you're not pregnant or you've never been pregnant, and all of a sudden breast milk starts coming out, that is also cause of concern. Swollen lymph nodes. Now, lymph nodes are small little tissues or structures where our body concentrates infection to be able to fight it off from a particular place. For example, if you were to shave the hair on your armpit, you might notice a hard kind of swelling in your armpit or anywhere else. And that sometimes is a center where the body fights off infection, maybe from the skin or the razor that you used. That is called a lymph node. So if your lymph nodes become swollen, whether they are painful or not, it's important for you to be able to have them checked. They're not always in the armpit. Sometimes they're at the collarbone. Sometimes they're in the middle of the chest. Anywhere around the breast, if you notice a firm, painless swelling, that could be a lymph node, not necessarily a lump. And it's important to have that checked out. Next slide, please. All right, so this is, I don't know if everybody can see, but this is a symptom chart of what they look like. Sorry, we had to use lemon because it makes it a little bit easier to see. But what I was describing is all there. The dimpling, the redness as you can see in the bottom row of the lemons. The second from the right, that's the redness. The dimpling is on the upper extreme right lemon, yeah. There's one where there's a fluid just next to the dimpling. There's one where the third one on the bottom row from the left, that one is when the nipple is retracted, all right? And then when there's a bump, all of these show a pictorial representation. So if you're able to get this picture just so that your mind kind of understands what a lump looks like, what retraction looks like, what skin changes look like, what the dimpling, bleeding, discharge, and everything looks like, then this would be important. I think this is a better representation than putting actual breasts on photo. But this is basically for us to understand what to look out for. For people who are at high risk, this is something you can even put up somewhere next to you so that people always understand, or if you're a medical professional, this is something that can also help your clients for them to be able to understand what to look out for. All right. Let's go to the next slide, please. Now, as I mentioned before, breast cancer can never be managed by one person. The first person a woman can see probably is her gynecologist. Some women go straight to the breast specialist, which is fantastic, but many times women maybe do not know the breast specialist or do not have a relationship or a rapport with the breast specialist, so they will go to their gynecologist and complain about something in their breast. But eventually, when breast cancer is detected, it is multidisciplinary. We require an oncologist, who is the person who administers chemotherapy and radiotherapy. We require a surgeon, a breast surgeon. That is a person who will ideally excise the tumor or be able to take a biopsy from the tumor to confirm to us. Once a biopsy is taken, which is a tiny little piece of the tumor, we go and we look at it under a microscope so that it can tell us which type of breast cancer is there. We have adenocarcinomas. We have different types histologically. I don't want to confuse you or bore you with the details, but not all breast cancers are the same. They can be very different, and their microscopic differences are the ones that lead us to treat them differently. Some of them respond to chemotherapy. Some of them do not. Some of them respond to radiotherapy, some of them do not. Ideally, If possible, all of them need to be removed surgically. Some will require chemo or radio afterwards, but the type, the microscopic type, is the most important part of us understanding the breast cancer, because it then directs how we should go in terms of the chemo, radio, and other management. Then we also need a plastic surgeon to be able to reconstruct the breast after it has been removed. Some women choose to go with the reconstruction just so that the skin looks better. Some women want to have, you know, an implant put so that they don't look like they don't have a breast. These are things that are done much later. They are not available to all people. If you have very, you know, extensive breast cancer, it may not be possible for you, but it's important that a plastic surgeon is involved to be able to allow the client to have dignity even after the breast has been removed. Maybe they do not like the appearance. Maybe they want to look better afterwards. In some cases, there is reconstruction that can be done by a plastic surgeon or an encore plastic surgeon to be able to reconstruct the breast and allow it to look as normal as possible after the cancer surgery. It's also important for us to have a psychotherapist, because any cancer diagnosis truly does affect mental health. And it's very important that the therapist is able to manage that, not just for the client, but also for the entire family. It is very distressing to receive a cancer diagnosis in the family, more so, of course, for oneself. And we definitely need to protect our mental health around this diagnosis, and just to have somebody be able to, sorry, I was receiving a phone call, just to have someone be able to guide us through that entire process of how to be able to mentally manage this. Gynecologist is also important, because sometimes women who receive breast cancer therapy, whether it's hormonal or chemotherapy or radiotherapy, the chemotherapy or the radiotherapy can affect our ovaries, all right? And when it affects our ovaries, we start to produce less estrogen and progesterone, and that is good for the breast cancer, because those are the triggers, yeah? But for a woman, the decrease in estrogen and progesterone can affect her in terms of low libido, can affect her in terms of vaginal dryness, can affect even just the way the anatomy of the vagina is, because it hugely relies on estrogen and progesterone to be able to lubricate, to be able to have enough collagen and the rest. So a gynecologist will also be involved, because a lot of women suffer in silence when they get breast cancer, and they get female sexual dysfunction after breast cancer. That's where I generally step in. I tend to help patients who have had breast cancer be able to regain their intimate wellness together with a psychotherapist or a sex therapist, and we're able to offer certain therapies, you know, such as radiofrequency therapy, such as dilatation of the vagina, such as Botox. There's a number of cosmetic solutions that are safe, that are non-hormonal, and that, you know, will not trigger the cancer, but will be able to help in the regaining of the sexual health of a woman after a cancer diagnosis. So endocrine therapy is, some women tend to get hormonal therapy to be able to counteract the hormones that are being produced in their body that are triggering the cancer. Endocrine therapy is called hormone therapy. So for this particular treatment, we have to see, does this woman have predominantly an estrogen receptor positive cancer or a progesterone receptor positive cancer? It's very important for us to know, so that we give the hormone that counteract that. It's also a huge therapy form in cancer therapy. And then, of course, there's the standard chemotherapy and radiotherapy. And so many of these things need to be used in combination for wholesome breast cancer care. It's not just about cutting it out and leaving a woman looking maimed. It's about, okay, how do we now recover the life afterwards? How do we take care of her mental health? How do we take care of her intimate wellness? How do we take care of how her breast looks afterwards? How do we take care of her family? How much chemotherapy is needed? What can we add to the radiotherapy? It's really wholesome care. If anyone is being managed for breast cancer by one doctor, they're really doing a disservice to the patient. It's always, always a huge team. All right, next slide, please. So prognosis is basically when a woman is diagnosed with cancer, what is this gonna look like for her? This really depends on a number of things. This means, what is the cause of this disease? How long will she be able to survive with it? What is her journey going to look like once the diagnosis is made? And this depends on very many things. It depends on, is the patient menopausal or not? Because when a patient is not menopausal, remember, she will continue to produce estrogen and progesterone, and that can re-trigger the cancer, even if it had been managed properly. So women who are not menopausal, their journey will be different from somebody who is already menopausal and is barely producing any estrogen or progesterone. Then it also depends on the stage of the disease. For example, if it's stage 4 disease and we have metastasis to the brain, to the bone, to the lung, and those are the common areas, then of course the prognosis will not be good, because now we're dealing with cancer in other organs and not just the breast. Or we're not dealing with cancer that is one lump, but it's an entire breast, or maybe it is both breasts. So really the stage of the disease does matter. Then it matters the grade of the primary tumor, meaning, is it a grade 1, 2, 3, like these different grades of the primary tumor, and that generally affects. The primary is the original tumor. So if breast cancer is the original tumor and it's now spreads to the brain or the lungs, then the brain and the lungs become the secondary tumors. They're not the primary. The primary is the breast. So we have to always see what is the grade of the very first tumor. And when we do imaging, for example, if we were to do an MRI of the brain for a person who has breast cancer that has spread to the brain, we are able to tell that this tumor in the brain has come from the breast. Or we are able to tell that this one is actually not from the breast, it has come from a different organ, including bone tumors. If you have a tumor in your bone, when we do our imaging, we are able to tell that this one came from the breast and not from a different organ. So that is also very important. And then, as I had mentioned before, receptor status of the tumor. Is this a predominantly estrogen receptor sensitive tumor or a progesterone? Meaning, does this tumor get triggered by estrogen or does it get triggered by progesterone? And that also tells us how long the patient will be able to live, and also what will be their course of their journey. Will it be more difficult or will it be a little bit easier, depending on the receptor status? And last but not least, we must know the histology. Meaning, is it a mucinous tumor? Is it a medullary tumor? Is it a tubular tumor? Like, we need to know microscopically which type of tumor is this, because there are very many types with very different prognosis. Some are extremely aggressive and can kill a patient within 6 months, and some can actually be managed very comfortably for several years. So it's important to know the histologic type, and this histology is usually known through a biopsy. So the doctor will ideally take a small piece. We go, we check, okay, which tumor are we dealing with? Okay, it's mucinous. Then now we say, okay, we're going to do surgery. Maybe we'll want to do radiotherapy. Maybe we'll want to do chemotherapy. So the type is very important. Some are very unaggressive and they're not so terrible, but some are very short lifespan tumors. So it's very important to know the histology. All right, so I hope all of this gives you a slightly clearer picture for us to be able to understand what we're dealing with, what to look out for, who to go to, what mode of investigations can help, and what the course will look like. But the most important thing, if you get nothing out of this presentation, I'd like you to understand what symptoms to look out for, but also that there are solutions for this. And a person who has breast cancer should live a life that is as similar to normal as possible. There is hope. There are very many solutions to a lot of problems that we didn't have previously, and one needs to receive very, very wholesome care. You can just have the last slide. Let's have the last slide, please. Thank you very much.
Thank you very much, Daktari. That was really informative and a very interactive session. I'm seeing on our chat box we have quite a number of questions. Do you want me to help you read out them, or you can be able to access them?
You can read out for me, kindly, if that's okay.
Thank you. I'll start with the first question, and again, I want to thank our audience for joining in. Someone is asking, does family planning contribute to estrogen in our bodies?
Yes, it does. Yes, it does. When it's not all family planning, by the way, it is the family planning that is hormonal, and specifically the one that has estrogen and progesterone. Mostly family planning that is pure progesterone does not have the same cancer risk as the ones that contain estrogen. So estrogen is a bigger problem for the breast than progesterone. So somebody who is taking a combined oral contraceptive pill, the family planning pills, yeah, that have estrogen, they are exposing their breast to an increased risk of breast cancer. It is not a huge risk, but it is there, and we cannot ignore it. And that is the reason why, if necessary, we have to sometimes prescribe the family planning pill that has estrogen and progesterone. For example, when women have irregular periods and they're trying to regularize their period because they are trying to conceive, then sometimes we have to give them medication. Or if we're prescribing oral contraceptive pills, we need to warn the patients that this is the risk and that the length of time that they use them is correlated to their cancer risk. So it's something that you should not use for very extended periods of time, but the progesterone only are much safer. For example, the progesterone only intrauterine device or the implant, those ones do not carry estrogen, and so the breast cancer risk is not the same. But remember, for somebody who already has breast cancer, then ideally they should not use anything hormonal, because remember when we talked about estrogen receptor sensitivity and progesterone receptor sensitivity, if somebody has a tumor, already has a breast cancer that is progesterone sensitive, then they should not be using even the contraceptives that have progesterone. But in terms of risks and triggers, the estrogen ones are the ones that carry a higher risk.
We can't hear you, Zainab.
The second question, Dr. is it only the maternal side of the family that predisposes someone to cancer, or does the paternal side play a role?
The paternal side does play a role, but the maternal side has a higher risk. The maternal side definitely has a higher risk. If you go to see a doctor and you tell them that your mother had breast cancer, you will notice it even in their face and how quickly they try to investigate you. The paternal side does play a role, but it does not carry the same weight as the maternal side.
Another question is, should benign lumps be removed, or can one stay with them as long as they can do checkups often? And in addition to that, what happens when one is pregnant and they have breast cancer?
Okay, that's a really good question. Generally, when you do your annual screening, meaning you do your annual breast ultrasounds, we diagnose very many women with benign lumps. Most of the time, they are fibroadenomas. These are generally hormonal-based lumps, and they are not cancerous. Now, usually, my action is to send them to a breast specialist for two things. First of all, that they can confirm that this is actually a fibroadenoma or a benign lump, because sometimes women have been misdiagnosed with benign lumps when they're actually cancerous. So the confirmation needs to be done, and usually a breast surgeon is best for that. Now, once the confirmation has been done, it will also depend on the size. If it is a massive fibroadenoma, maybe 10 centimeters, it will have to be removed just for the comfort of the patient, not because it is cancerous, not because it's causing any problem, but because it's hurting or it's occupying a particular space, or it is distorting the shape of the breast. So that one will have to be removed. For those that are small, there is room for observation and checkups in certain cases, but that green light must be given by the breast surgeon, because sometimes you might have a mistake made by a sonographer. Sometimes you may have a mistake made by anybody who takes care of the patient. But once a fibroadenoma diagnosis is made, it's important for the breast surgeon to see, to confirm that it is actually a fibroadenoma, to see the size, to see the symptoms in the patient. And if the patient is comfortable and it's truly a fibroadenoma and it's small, it can be managed by observation and frequent checkups. So yes, there is room for that. They don't all have to be removed. In fact, patients should be very cautious from when they're told to remove a non-cancerous breast lump. They should probably seek a second opinion. If two breast specialists are on the same page about removing a non-cancerous lump, then it should be removed. But otherwise, if it's truly non-cancerous and not causing major discomfort, we should not rush to have them removed. In terms of what happens in breast cancer in pregnancy, I have had a number of patients who I have diagnosed with breast cancer in pregnancy. I'm starting to do routine ultrasounds for women in early pregnancy, especially women who have not had any breast screening for the last 12 months and now have found themselves pregnant. It depends on very many things. It depends on how early it's diagnosed. It depends again on the histologic type. It depends on, how far it has progressed the stage. If it's just a small lump that has not gone anywhere else, we do have room for surgery. Some of my patients have undergone breast lump removal or lumpectomy in pregnancy. Surgery in pregnancy is safe, by the way. It's just important for the entire team to be aware, because the anesthesia needs to be managed in a particular way. But yes, surgery is safe in pregnancy. And it's life-saving, it becomes a very moral decision. Women are like, okay, should I proceed with the treatment or should I save the pregnancy? We like to be able to do both. Nowadays, we have chemotherapy that is actually, very minimally intrusive to the baby, meaning it will not have major effect on the pregnancy. And it's possible to go through the chemotherapy during pregnancy. We like to reserve things like radiotherapy to after delivery, because it destroys the ovary sometimes. And the ovary is the one that is producing the hormones to sustain the pregnancy. So in short, it depends on very many things, but it is possible to manage breast cancer in pregnancy, have a surgery, have chemotherapy that is safe to the baby. But again, it really depends on how early we find it, what type, and the stage.
Thank you for that response. I'll pick two questions combined because I can see the similarity in them. One is asking, when the doctors tell the patients that they are cancer-free, is it true? What are the correlation between the breast cancer and brain tumor? And in addition to that, men get cancer and men get breast cancer. In a case study of genetically acquired breast cancer through my maternal grandparents, I think the is trying to say that he got breast cancer secondary to the maternal from maternal side.
The maternal relatives,
Yes.
yes. Let me start with that one. Yes, that is very possible. As I mentioned, the maternal gene is very strong in breast cancer. Men can get breast cancer because men have breast tissue. They may not be exposed to the same things we are, like contraception, breastfeeding, pregnancy, and the rest, but they do have breast tissue as much as it is smaller than ours, and they can get breast cancer, especially if they have very strong family history, or if they expose themselves to things like smoking and alcohol. It's still very much possible. I saw someone asking along the group how the checkups are done for men. It is a self-exam, just the way I had described for women. It is also important for men to do. Men would probably not be as eager to do it, but it's quite important for them to check, especially when they are aware of their risk factors. Yeah. But remember, breast cancer can occur with 0 risk factors. So it's always important to check. It takes less than 5 minutes. It really costs nothing. Sorry. So in terms of, yes, breast cancer can be gotten by men. The other question that you asked, sorry, please repeat, because there were 3 questions.
The other question is, do the symptoms show the stage of cancer? Do the symptoms show the stage of cancer, and is it safe to take a biopsy of a sick person?
Okay, that's not the two questions you had asked me before. Sorry, you had combined
The last
first
one,
two questions.
actually, the last one was about getting breast cancer and also the relation between breast cancer to brain.
Ah, yes, yes. So the association between breast cancer and the brain is that usually the breast cancer in a higher stage can spread to the brain, or we call it metastasis. All right. So women who have breast cancer, there is a high likelihood that it can spread to the brain. It's very important to note that it's not a direct association, but usually it's one of the places that it can spread to: the lung, the brain, the bone. And there was another question just before the one for spreading.
Yes. Actually, it was about family planning and in relation to getting breast lumps, and if they
Yes, I
can be
think I've
removed.
answered that.
Yeah.
I think I've answered that.
Yeah.
Sorry, you can go to the next question.
Thank you. The next question. I wonder, Daktari, why do patients have to suffer so much, especially when it is evident there is no cure? Isn't it allowed to the end of life of the patient to minimize the pain and suffering?
I will go to that question, but there are other two questions that you asked before this one that I didn't answer.
It was about symptoms. Do symptoms at what stage do symptoms show when you have breast cancer, and is it safe to take biopsy of a sick person?
Okay, I'm not really sure what the person means by a sick person. If you mean a person who has breast cancer, then yes, sometimes we have to take biopsies. Sometimes removal of the whole lump is actually the biopsy process, right? So we're removing the whole lump. But yes, it is safe to take a biopsy. If one is asking whether taking the biopsy will cause spread of the cancer, it will not. All right. It is important to take a biopsy because if we don't take a biopsy, we don't know which type of cancer we're dealing with. We just know it's breast cancer. And remember, we've mentioned that there are many types. And if we don't know the type of the breast cancer that you have, we cannot know what the management will be. We don't know if you need chemotherapy. We don't know if you need radiotherapy. We don't know which type of chemotherapy because we have different types of chemotherapy. Not all chemotherapies are the same. So we have to know which type there is. It is actually very safe. Now, in terms of symptoms versus the stage, I'm not able to answer that question. There are women who have a symptom on their breast, even when it's a very early cancer. And there are women who will have a symptom on their breast when it is stage 4, cancer or stage 3 cancer. So the symptoms do not relate with the stage. And that is the reason we must always present the symptoms to the doctor as early as possible so that we do not go to an advanced stage. I wish there was a way we could say, as soon as you see dimpling, you are in stage 3. It doesn't work like that. Any symptom can be related to any stage, which is the reason why as soon as the symptom comes, it's important for us to see the doctor. Have I answered the question?
We can't hear you, Zainab.
Okay, it's okay. I think I'll just have to use the one for Justus for now. Thank you so much, Daktari. The far we have gone, and we want to appreciate your time. It's unfortunate that we're now running out of time, but just to pick one or two questions before we revert to the list. Someone is quite concerned about the IVF and chemotherapy. So they wanted to understand, is IVF the only solution when you are having chemotherapy, or is there any other option?
It's a little bit of a difficult question to answer because not all women who undergo chemotherapy become infertile. Just because you've undergone chemotherapy doesn't mean that you will be infertile. There are women who undergo chemotherapy successfully, and they're able, depending on the stage, of course, and the type of cancer that they had, once the doctor has declared them either in remission or cancer-free, then they can actually go ahead to conceive later on. That being said, there are some women who choose to have IVF and even surrogacy because they do not want to undergo the pregnancy process after having gone through chemotherapy. So surrogacy is one of the options. Sometimes, depending on the kind of chemotherapy or radiotherapy or treatment that we're going to administer to the patient, sometimes we advise them to freeze their eggs in advance of the treatment, so that we're able to save them, so that regardless of how the course of chemotherapy or radiotherapy goes, once they are done with that, they can either choose to have a surrogate, or they can come back and get their frozen eggs or their frozen embryos implanted in them through IVF. So yes, IVF is an option for those undergoing chemo or radio, but it's not the only option. Some women choose to go through all of it, and when they're done, they choose to have a natural pregnancy. And that is possible as long as the chemotherapy and the radiotherapy that you received is not going to damage your ovaries significantly. So women who want to conceive in the future need to discuss with their oncologist and their gynecologist, what are my chances of conceiving in the future? This chemo that I'm being given, this radio that I'm being given, is it going to destroy my ovaries to the point that I cannot conceive in future? And is it something that I want to preserve right now? Or is it something that will be gentle on the ovary and I can conceive later on when everything is settled? So it's not always the only option. I hope I've answered that question.
Thank you, Daktari. There's a concern here. What message can you give to men with spouses who are undergoing chemotherapy and still new in a marriage?
Yeah, that's a really tough question. And I have had to handle such clients. In fact, I recently had a client who got diagnosed with breast cancer in pregnancy in a new marriage. It's a very difficult thing to go through. What I would advise them is this. I'd advise them to get a lot of mental health and emotional support for both, to be able to go through psychotherapy, to be able to understand the disease and what is required of everyone in terms of support. Because to become an effective caregiver or a supportive caregiver, you yourself need to be supported. So I would say to really, really delve into and invest into mental health support or psychotherapy support for the partner who's now going to become a caregiver. And then also to update themselves and just be knowledgeable about everything to do with their partner's condition, meaning the stage, the medication, the prognosis, the procedures that will be involved, the chemo, the radio, the surgery. So be abreast in terms of knowledge and also get lots of psychotherapeutic support, because it is what will carry them through. To give their partner a lot of love and patience. It's a difficult diagnosis on their own, and many times cancer patients also feel guilty about the kind of burden that they're putting on their families. So it's bad enough that they themselves are unwell, but they also worry about the effect that they are having on their families. So when their families are more supportive, it allows them to at least let go of one burden, to be able to deal with their illness emotionally as well. There's no right answer to that question. I can't give you the blueprint to be able to, support a person, but I can tell you, once you're emotionally supported and knowledgeable, you become a better caregiver to the person who has just been diagnosed. And it should not allow, the condition should not allow the marriage to break, because not just because of the religious and emotional and other vows and moral vows that we make, but because this is something that can be overcome.
Thank you so much, Daktari, and to our viewers, just to join you, if you're going through such an experience, APA Insurance is open. You can reach us to us through an email we are going to share shortly. We have specialists on board, we have counselors, we have a team that will walk you through this hard time, and we are here to support you. So kindly feel free to reach out to APA. We'll be waiting so that we can work together with you. Now, I just want to take two more because of time, Daktari. I would also want to release you because I know you are held up. What are the latest advancements in the breast cancer treatment and research currently? Any late, research that maybe could pull or give a light to what is happening right now with cancer?
That's a very difficult question to answer. I would need to give an entire course on that. And also, I'm not a breast cancer specialist, neither am I a breast surgeon. But one thing that I can say has been very instrumental in all cancers, not just in breast cancer recently, is immunotherapy. We have ways of modifying our immune system so that it stops to react to the cancer in an aggressive manner. And I think that, for me, is the most breakthrough that we have made in a very long time. There must be much more others. It's not my field of expertise, but one thing that I can mention, even in my own field of the gynecological cancers, is immunotherapy. So basically, we're giving you medication. When your body detects that there is cancer, it also starts to fight it. Yeah. So we want to modify that fighting response. We want to either make it fight harder or make it not react as much. And that ideally helps in terms of the cancer management, because once a body gets cancer, the body's response is also kind of can also advance the cancer or prevent the advance of the cancer. So it's very important for us to be able to look into immunotherapy. If anybody has breast cancer or any other cancer, I would strongly suggest speaking to your oncologist about immunotherapy. Immunotherapy is really the new thing in cancer treatment.
Thank you, Daktari, for that. Do you think or do you agree that chemotherapy treatment is harmful to the healthy cells in the body? How true is this?
Yes, chemotherapy can be harmful to the healthy cells in the body, absolutely. When chemotherapy kills cells, it can kill cancer cells and also the normal cells. But and which is the reason why patients who have chemotherapy lose their hair, lose their teeth, sometimes their nails, because it will destroy the healthy cells in the body as well. So yes, however, when we look at the risk versus the benefit, people would say, I would the cancer to progress. So if the chemotherapy is going to kill the cancer cells together with some healthy cells, then I would rather it does that. And then later on, my healthy cells will regenerate, if possible, depending on, of course, the stage and the type. Everything in cancer depends on the stage and the type of cancer. So if the stage is low and the type is non-aggressive, then after chemotherapy, all of this can recover. So yes, it does kill healthy cells, but the cost of preserving your healthy cells is allowing the abnormal or cancerous cells to progress. So when you do a risk-benefit analysis, so to speak, you'd rather have the cancer cells killed together with some of the healthy cells. And then when that is over, the healthy cells will regenerate.
Thank you, Daktari. I think we would like to end it there. I know there are a lot of questions, but time is not on our side. We apologize, we started a bit late, but I have shared the email address. I've shared the WhatsApp number. For those of us whose questions have not been tackled, kindly reach us on the same, and we'll be able to share with Daktari, and Daktari will respond to you directly. Also share with us your email addresses so that we can also be able to get in touch.
I'm also happy to share some responses via my social media handles. If anybody would like to maybe give something that is personal that they don't want to display here, my Instagram handle is Dr. Kristina, and or you can to Alora Medical Practice on Instagram and on Facebook.
Okay, Daktari, maybe you just mention again where you are located. I had mentioned earlier on. You can just
Yes.
tell our viewers where they can reach you out.
I am in Alora Medical Practice in 40 Suites on Hospital Road, opposite Nairobi Hospital, on 6th floor, Suite 601.
Thank you so much, Daktari. We really appreciate your time, and to our viewers, we are humbled. We're sorry because of time, we are not able to move on. I know you have a lot of questions. We try as much as possible to respond to them. And we'll also create another opportunity to bring Dr. Kristina back. Daktari, just before I let you off the hook, you are a cosmetic
gynecologist.
cosmetic gynecologist. What do you do that makes you a cosmetic gynecologist to our lady viewers?
So basically what we do is we treat female sexual dysfunction. We help women who have libido issues, orgasm issues. We help women who have issues with laxity after delivery. Maybe they have, a lot of vaginal looseness after delivery, or maybe they underwent FGM and they require reconstruction, or maybe towards menopause, they're going through a lot of dryness because of menopause. We have a lot of non-surgical solutions that cover that. We also do aesthetic reconstruction of the external female genital system, not necessarily for women who've gone through FGM, but women who maybe do not like the way something looks. We do a lot of platelet-rich plasma therapy to enhance, our sexual experiences. We have an entire variety of about 8-10 cosmetic gynecology products that we offer women with various problems, even women who do not have necessarily sexual dysfunction, but they would like to improve their sexual intimacy. We have a lot of non-surgical and also surgical products that we offer for that.
Wow, thank you, Daktari. I'm sure this will form our next webinar. I'm sure we have a lot of issues to address. I hope this includes plus men. We're going to...
No, no, it doesn't,
only for the
unfortunately.
ladies, yeah?
Yeah,
So
for the ladies.
this will form our next webinar. Kindly be on the lookout. Then we can invite Dr. Kristina back again so that we can address these issues that really affect our ladies. So apart from that, thank you very much, Daktari. We are humbled. We would like to let you off the hook because we know your patients are waiting for you. And us from Apollo Center, we're so grateful that you could make a time to join us this morning. We are humbled. We appreciate you. And again, on behalf of our leader at the Wellness Department, Ms. Jemima Mbugwa, our head of health, David Momo, our retention manager, Sheila Gishui, our marketing team, Charles Mbugwa, and the entire management of the APA fraternity. We want to thank all our viewers who gave us an opportunity this morning. And we wish you a very, very, very beautiful weekend ahead as you continue being part of APA, the home of happiness. So thank you so much, and may God bless you.
Thank you.